I'm Dr. Ken Shepke, and today we're going to be speaking about COVID-19 vaccinations, and I'll be giving you an update on the current state in the United States with the various vaccine candidates, hopefully to give you enough information so you can stay informed yourself and make an informed decision on whether you might be interested in getting one of these vaccines, assuming they ultimately become available. So a little information about the vaccine history in the world. It literally took us thousands of years to get our first vaccine. That was back in 1796 with Edward Jenner, who realized that vaccinating somebody with cowpox protected them from smallpox. In fact, that's where the name vaccination came from, because the name for cow is vaca, and the name for the virus that causes cowpox is vaccinia. And so Edward Jenner named this process vaccination. There's been a number of advances in technology of vaccines over the years, and there are several ways we can do vaccines. One is you can inactivate or kill the virus, and that's one of the technologies you see for the hepatitis A vaccine. You can use an alive virus, but you can grow the virus over time and teach it to be weak. So that's a live attenuated or weakened virus, and we use that with the measles vaccine. You can use genetic manipulation of benign viruses, and that's something that AstraZeneca and Johnson & Johnson are doing for their COVID vaccine candidates. Or you could use a piece of the virus. So rather than using an entire virus, you can actually take a piece of the virus that you want to create the immune response to, such as the purified spike protein that Novavax is doing. And then the more recent way of creating vaccines, just in the last 10 or 15 years or so, there's been a lot of effort put into messenger RNA vaccines. And these are not viruses at all. These are man-made virus-like lipid nanoparticles. And Pfizer and Moderna are the two most prominent ones that are creating this type of vaccine. So one of the things I see, and one of the concerns, frankly, is how do we get a vaccine so quickly? And does that mean that science cut some corners and we can't really rely on these vaccines? And really, I'm going to give you information on it, but I don't think that that's the case. I think it's just natural, advancement in science. So like I said, the smallpox vaccine took literally thousands of years for us to get our first vaccine. And then the next major advances took hundreds of years. And even the measles vaccine, to get a live attenuated vaccine, took them 10 years to get the strain of measles weakened virus that we can use for a vaccine. And then the Human Genome Project really created an opportunity for us to make some major advances and technological leaps in vaccine therapy. I'm going to go over why that particular project, while it doesn't really sound like it's related to vaccination, why it actually is very much related to how we can make vaccines so quickly. So if you remember, the Human Genome Project was a major thing a couple of decades ago. Cost $3 billion. Over 200 labs in the United States plus 18 other countries collaborated in the effort to decode the human genome. It took 13 years to decode the human genome from 1990 to 2003. That's how long it took. So it was a major undertaking, took a long time. And because of that effort, it really advanced our understanding of genetic decoding. And nowadays, you can decode the entire human genome in 24 hours for less than $1,000. So that's the major leaps and bounds that have occurred based on that technology being advanced to this point. And the reason why that's important in terms of vaccinations is because of this. If you look at the genetic material in a human, it's roughly 6 billion bases in a human genome. Compare that to a fruit fly, which is only 123 million bases, or even to a bacteria like E. coli, that's 5 million bases. And then compare it to the COVID virus. The SARS-CoV-2 is the name of the virus that causes COVID-19. That's only 30,000 bases. So literally, it's not even a drop in the bucket compared to the human genome. So as you can imagine, we can figure out the entire genetic sequence of the virus really, really quickly. And that's why we were able to develop this messenger RNA vaccine so quickly. So messenger RNA vaccines is not a virus. That's one of the key pieces. Messenger RNA is basically a piece of genetic material that is a recipe to produce a protein. And your body does this every single day. It makes all sorts of proteins, but your body also has an immune system that recognizes foreign proteins, proteins that should not be existing in our body. So one of the ideas behind messenger RNA is that you use this recipe to create a protein, and you get that into a cell, make the cell make this protein, and then it activates your immune system. So the really cool thing about these messenger RNA vaccines is that you can use this to create any protein that you want. And one of the things that researchers are using this for is even to develop therapy for cancer. Because in addition to creating vaccines and create proteins for infectious diseases, when you look at cancer, a lot of times cancer cells, they create mutated proteins. So in addition to being mutated cells, they begin to create proteins that are not normally seen in your body. So if you can get the genetic material or the recipe, so to speak, for that mutated protein and put it in one of these lipid nanoparticles, then you can inject it and develop an immune response and teach your immune system to kill any cells that are expressing that mutated protein. And in fact, we are seeing some improvements in therapy for melanoma using exactly this type of technology. So again, this is not, it's newer, but it's not brand new just for the pandemic. Researchers have been working on these type of vaccines for a while. Now, the nice thing about this is it's ultra rapid technology. I mean, you can really get this, you can get the genetic code for whatever you're trying to make really quickly, wrap it up into these nanoparticles and create it. In fact, in this instance, it took 62 days. That's it, 62 days, not thousands of years, not hundreds of years, not 10 years, 62 days from the moment of deciphering the genetic code of the SARS-CoV-2 virus. Again, that's the virus that causes COVID-19. From that point to developing a messenger RNA lipid nanoparticle vaccine and injecting it to the first human. So now you wonder, if we had a vaccine within 62 days, why are we not using it right now? And that's where the next piece of vaccine development comes along, which is all the safety and efficacy studies. So the way these studies work is you give half your study population the vaccine, and you give half your study population a placebo that you would expect not to develop any sort of immune response. But then you have to wait some time, and as those people go about their daily lives, some of them are going to come in contact with the infection that you're trying to protect them from. And then after you've had a certain number of people in your study get infected, then you look at it and you say, all right, of the people that developed the infection, how many got the placebo and how many got the vaccine? And you compare those two groups and you say, oh, well, look, the folks that got the placebo, lots of them got the disease, but the ones that got the vaccine, not too many got them. That's how you calculate your efficacy ratio. Now, one of the reasons why you don't just take the messenger RNA and inject it into the body straight like that is because messenger RNA is a very fragile molecule. And your body has all these enzymes that break down the messenger RNA and it'll just destroy it immediately. So that's where the technology to protect the messenger RNA by putting it inside these lipid nanoparticles came from. Now, the lipid nanoparticle is basically a little tiny ball of fat. And the messenger RNA gets inside that, and that protects it from the enzymes. And the important thing is when you inject that, the lining of your cell also has lipids on it. So those two lipid layers then come together and allows the messenger RNA to enter your cell. Once it's inside your cell, then that messenger RNA comes out, and then the cell's normal machinery in the cytoplasm, or the liquid part of the cell, takes over and takes that messenger RNA and starts creating the protein. In this case, it creates the spike protein. Now, the spike protein on the COVID virus is basically the attachment molecule. That's where the virus, that's the protein the virus uses to attach to our cells. And once it attaches to our cells, it gets inside the cell, and that's how it gets to replicate itself. So making that spike protein is an important step because we want our immune system to recognize that so that antibodies can be developed against that. And I want to talk about that in a moment. So let's talk about the two main messenger RNA vaccines that are very soon. In fact, Pfizer, I think, just filed for emergency use authorization with the FDA. Moderna is just going to be literally just behind it by a matter of weeks. Let's talk about the technology behind these two. So first, again, this is a messenger RNA vaccine. It is not a virus. It does, however, have to be stored. Again, the messenger RNA is a very fragile molecule, and it has to be stored at a very ultra cold rate. So in this case, negative 80 degrees Celsius, if you want to store this vaccine for long term. So in this case, for 6 months, if you want to store it for 6 months, you have to put it down to this ultra cold temperature. Now, a normal freezer does not do this. So you do need a special ultra cold freezer to get down to that cold. However, you could put the vaccine in a regular refrigerator, and then it's good for 5 days. Not a lot of time, but that should be plenty of time if you have an efficient vaccination scheduling system so that you can use up the vaccine before it goes stale. Once you take the vaccine to room temperature, now you've only got about 6 hours to use it up before it goes bad. Now, in the Pfizer study, they had 44,000 participants. They had a good diverse background, which is fantastic. They had zero safety concerns, a 95% efficacy rate, which is fantastic, and very importantly, both antibody and T-cell immunity. I want to talk about that just for a moment here. So if you look at your immune system, you can think of it like a military, right? And the military has different branches. So you have like the Army, your ground forces, that would be like your antibodies. And then you have like your Air Force, and that's like your T cells. So basically what the antibodies are, they're like these proteins that your immune system makes that go out and they attach to the spike protein and basically cover them all up. And if you cover up all of the virus's spike proteins, then the virus doesn't have any attachment point where it can attach to the cell. So now it can't get into your cell because you've covered up all the spike proteins with antibodies. That's one part of your immune system. The other part of the immune system is the T cell part of the immune system. And it's a little harder to measure T cell immunity. Antibody testing is pretty simple. T cell immunity is a little more complex in the lab to figure out whether you have T cell immunity. But what the T cells do is they basically recognize cells that have been infected with the target antigen, in this case, the spike protein. And then what happens in a normal infection is the virus gets into your healthy cell and starts reproducing itself. And in the process of reproducing itself, they start having all these spike proteins on the outside of the cell. The T cell then recognizes those spike proteins on the outside of what used to be a healthy cell, is now an infected cell, and realizes, hey, this cell's been taken over, it's now an infected cell, and it can kill that cell. In addition, the T cell also gets the cells that produce antibodies to ramp up their production. So the T cell is really important in viral infections like this, where you get the infection inside your cell. So we really want to see that antibody and T cell immunity for this particular disease. Now, the nice thing is that we are nearing the end of this process here, where we may get emergency use authorization sometime in December, and Pfizer, BioNTech, that collaboration thinks they may be able to deliver somewhere between 20 and 30 million doses, provided things go through and they get emergency use authorization. By the end of the year, they may be able to get 20 to 30 million doses out to us. Pfizer, because they have to ship it in ultra cold, they've developed their own dry ice shipping container, and you can actually store the vaccines in this sort of container. That's basically dry ice you're seeing there in that picture. As long as you continue to top off the dry ice, you can keep it in a container like this at the required ultra cold temperature for up to 15 days. Now, Moderna, very similar technology, not identical, but very similar, also a messenger RNA vaccines, also not a virus. Their stability, I guess, is a little bit different. You can actually put this at a regular freezer level. So not the ultra cold freezer, but like a regular freezer temperature. You can store this at 6 months, so it's a little bit more stable, which is nice. You can put it in a regular refrigerator. So at refrigerator, but non-freezer temperatures now, just the regular refrigerator temperature for 7 days, and perhaps even as long as 30 days. Moderna did say on one of their webinars that they've got data that shows stability out to 30 days, but they're not officially saying that yet because they need the FDA to give them the thumbs up on their data on that. This, same like Pfizer, once it's open, you got 6 hours at room temperature to use it up. They also had a big study, 30,000 participants, also diverse background, zero safety concerns in this one also in their study so far, and greater than 94%. In fact, it was 94.5% effective. Also, both antibody and T-cell immunity, which is fantastic. And they also think they can get, assuming the process goes through and the FDA gives them a thumbs up on their emergency use authorization, they may be able to do up to 20 million doses available before the end of 2020. Now, I do want to go over this efficacy thing, just a little more depth. It's the fact that they are 94, 95% efficacy in their studies. This is a grand slam. And the reason why I say that is because some of our best vaccines in history, like the measles, for example, has high 90% efficacy rates. But if you look at some of our more routine vaccines, like the influenza shot that many of us get every single year, that averages about 40%, 40% efficacy. So to get something that is like literally on par with some of the best vaccines we've ever had, it's a grand slam. It's great news for the world for this pandemic. Now, vaccine supplies are going to be included with shipments of these vaccines. So it'll be coming with the needles, the syringes. It might not have enough PPE supplies, particularly gloves, as I was reading into this. So if you're going to be delivering vaccines, you might want to make sure you've got enough PPE, particularly the gloves. I want to talk a little bit about AstraZeneca and some of the other three that are in the pipeline for the United States into phase 3 trials. AstraZeneca is using a chimpanzee adenovirus. This is a benign virus that causes a cold in chimpanzees that they've genetically modified so they cannot reproduce itself. And they've added the genetic material that makes the COVID-19 spike protein to that. So when you get injected with this, this is older technology. It's kind of something that's been done in the past for vaccines. Takes a little bit longer, which is why they're not as far along as the newer messenger RNA technology. But they're up there. I mean, they're getting pretty close to finishing their phase 3 trial as well. The good news from AstraZeneca is their early results show both an antibody and T-cell immune response at high levels as well. And they think they'll be ready to apply for emergency use authorization in early 2021. The Johnson & Johnson vaccine is similar to AstraZeneca. It's also an adenovirus that has been made weak, that's unable to replicate, but they added the genetic code to it for the spike protein for COVID, also showing good T-cell and antibody response. The important thing about Johnson & Johnson vaccine is this is a one-shot vaccine. All of the others that we're looking at so far the plan is to have 2 shots, where you get your first shot and then you get a booster shot. In the case of Pfizer and Moderna, that's anywhere from 3 to 4 weeks between for those 2 companies' vaccine candidates. So you'll have to get the same shot twice for all of those. But the Johnson & Johnson, they're shooting to have a single shot, one shot, and you're done. You won't have to come back for a repeat shot. So that's one of the nice things about Johnson & Johnson's vaccine candidate. Novavax is the last one I'm going to cover. This also is not a virus. This is just a piece of a virus. Now, normally, when you use just a piece of a virus, it doesn't give you as strong an immune response unless you combine it with something called an adjuvant. An adjuvant is basically just something that stimulates your immune system. So that's what Novavax has done. They combined their purified spike protein with an adjuvant, and their early studies are also showing very promising results with both antibody and T-cell response. They're not as far along as the others that I've mentioned so far, and they don't think their phase 3 results will be ready until sometime in 2021. This also normal refrigerator storage should be fine for this, which is great news. Now, we may see a time where we've got multiple vaccines that have received emergency use authorization circulating within the United States. So this is an important point I want to make, that if you get one of the shots that require a single shot initially and then a booster shot roughly a month later, you have to make sure it's the same manufacturer. So, for example, if you get the Pfizer shot initially, you have to get the Pfizer shot as your second shot. You cannot mix and match these things. It's got to be the same shot both times. Now for our EMS colleagues, I do want to talk about some strategies for helping to roll out the vaccine. Now, EMS in Florida has played an enormous role to the public benefit for helping with this pandemic. I mean, they have helped with mass testing. They've helped with our long-term care population and helping them stay safe by going from all these different long-term care facilities and helping them with their infection control procedures, with their testing procedures, et cetera. They've just been tremendously versatile, lots of ingenious ways that the EMS has really helped the public on this. And just kudos to EMS in the state of Florida. You guys have just been rock stars. So I just want to look at how we may be able to roll out EMS to help with the mass vaccination programs that are coming up. And some potential strategies include these drive-through vaccination sites. Now, you imagine we've already set up these drive-through testing sites where people show up and do a little swab in the nose or the throat for COVID. Well, you could just simply swap out the test for the vaccine. And the pictures you're seeing here is exactly what they did, exactly this in Palm Beach County Fire Rescue, with Palm Beach County Fire Rescue and Palm Beach County Sheriff's Office collaborating to do a drive-through influenza program. It was a closed pod that they did there. And it was basically done not only to get the influenza vaccine out there, but as a dry run for when these COVID vaccines finally come through, they can simply swap out the influenza vaccine for the COVID vaccine. Now, you could do something like this for a walk-up as well. It doesn't have to be driving. You could just do this as a walk-up. But the point is that EMS has the ability to do this and just go from spot to spot because we're mobile and you can just set up these locations where the population needs you to have them. Now, one more thing with this, the manufacturers of these vaccines are suggesting, though, after you get your vaccine, that you wait for 15 minutes to make sure you don't develop any sort of immediate reaction or allergic reaction or something like that nature. So if you do one of these drive-up or walk-up sites, you will need to have a separate parking area or waiting area to make sure the folks are watched for that 15-minute interval. One more thing that we see EMS really be great at, and we had this in Florida when we had our hepatitis A epidemic. We saw that a lot of our population that have historical difficulty accessing the healthcare resources, such as our homeless population, were really getting hit pretty hard with hepatitis A. And a number of our EMS agencies developed mobile vaccination teams where they basically take the hospital or the ER to the patient rather than taking the patient to the ER. And in this case, they were basically bringing the vaccination team to the population, and they would bring a mobile vaccination team, kind of like you see in that picture on the bottom, to these population centers where these folks are congregating, and we're able to vaccinate them. And I can imagine us doing the same thing for the COVID when that happens. Now, long-term care facilities, Florida's done a fantastic job with this. They were really developed a number of best practices in terms of protecting our most vulnerable people in these long-term care facilities. And I could see these mobile EMS teams actually going out to all these long-term care facilities to beef up their ability to vaccinate not just their staff, but also the residents of these facilities. Rural areas do present an additional challenge because unlike some of these other more populated areas where they have these large agencies, there may not be any one single agency in a rural area that has enough bandwidth to create the team on their own. But we can set up sort of a hub and spoke model where you might have a hospital that might be able to spare a couple of staff members, and you may have a number of surrounding EMS agencies that can each spare one or two people to develop a sort of strike team for vaccinating folks. So now you can basically have these folks share the resources and then sort of go as a strike team to vaccinate folks, not only themselves, but their population in their rural areas. I can also see this working for as a force multiplier for hospitals. Hospitals are going to be playing a major role in the vaccination efforts, not only again for the frontline healthcare staff, but also for the public. Now, so far, Florida has been very fortunate that our hospitals have not been overwhelmed. That's a testament to all of us in Florida who's been really focusing on this, and to the populace who's been doing a good job keeping themselves safe. But there are definitely parts of the country where the hospitals they're becoming overwhelmed. And you can imagine that you really want to free up the hospital's nurses to be inside the hospital taking care of those critically ill patients, but you want to be able to still have a hospital vaccination program. That's where I could see us lending some paramedics to that effort, where the paramedic can relieve the nurse from the vaccination effort, so the nurse can go back inside the hospital, but we can then join their force, kind of like the hub and spoke model I described for the rural areas, where we can make that more efficient by combining forces between these agencies. Now, let's say you're an EMS agency in Florida and you want to know what steps to take to start vaccinating your personnel and get on board with this. Well, the good news is the Florida statute already does allow paramedics to get involved in immunizations. That's statute 401.272. But what you're going to need to do is contact your local county health department, have your EMS medical director sign an MOU with your local county health department, and then you're going to need to train your paramedics and show proof that you trained your paramedics. Now, fortunately, the CDC already has a number of really great educational videos. I got to review some of myself. I actually put it on there, the link for you. You can use that little link there to get that site. And you can use those videos to train your paramedics, and then just to have some sort of checklist or paper trail to prove that you trained your paramedics, and then develop your either closed or open point of dispensing model. So I hope I've informed you and given you a lot of information, and gotten you a little more up to date on the vaccines that are fortunately coming. That's right around the corner now, which is great news. And I wish you all good health and continue to stay safe. And thank you very much for watching.